Hi everybody, I'm Sarah. I was a renal registrar here for the last year, and I'm presenting a project that I did during that time. And that project was on clinical fluid assessment versus the body composition monitor. So these are two of our patients here. They're getting hemodialysis, and this is in the new satellite dialysis unit in Mangere. So as everyone probably knows, hemodialysis is one of our options for renal replacement therapy. And a key component of managing hemodialysis patients is assigning them a target weight. And that's the weight that we expect them to be when they finish their dialysis session. And that's achieved by programming the machine to take off a certain volume of fluid over a certain number of hours. And we decide how much fluid to take off based on their pre-dialysis weight. So if someone has a target weight of 100 kilos, and pre-dialysis they're 102 kilos, we program the machine to take 2 kilos off, and that's equal to 2 liters of fluid. So the target weight is assigned clinically. So the doctor assesses the patient, they ask them about their symptoms and their signs, and if they're lucky they'll have some more information like the recent trends in target weight, their medications and recent echoes. But despite everyone's best efforts, assigning a target weight is very difficult and it's very subjective. And it's really hampered by non-specific symptoms, unreliable signs, and technical difficulties. So for example, we're often trying to examine these people here while they're already on the dialysis machine, in a cramped space, hooked up, wearing clothes, sitting up straight. So you're really constrained in what you can do. In general, most doctors use a trial and error approach. So I see someone, they look overloaded to me, but they're already at their target weight. So I'll reduce their target weight by 2 kilos, but then I'll have to see them next week and see how they're doing and probably reduce it more. So that's fine, that's how we do it, but it is very time consuming, and it can also be confusing to patients because they think, oh, I've just got to my target, I finally made it, I worked hard, and now you just come along and change it. So yeah, it is difficult, but despite the difficulties, it is really important to try to get the target weight right, as being both overhydrated or underhydrated is associated with increased morbidity, mortality, and hospitalizations. So it seems clear that we need some help, and there has been a few different methods employed to try and help us, and these include things like doing lung ultrasound and using blood tests like BNP. But what we're going to focus on today is use of bioimpedance spectroscopy, and the machine that we have here is a Fresenius body composition monitor, also known as the BCM. So these work by transmitting alternating electric currents through the body and measuring the impedance, or the difficulty the current has getting through the tissues. And then this machine automatically calculates the person's body fluid volume. And this has been well validated against gold standard methods. But although we actually have a BCM here available to us, it's not part of our routine clinical practice. So we wanted to do a study looking at using the BCM. Our aims were to compare the BCM and clinical assessment. We also wanted to compare it with doctors of different grades. We were thinking that consultants might be better than regs, and regs might be better than house officers. And we also wanted to identify clinical factors that lead to inaccuracy. So for example, if someone has a higher BMI, does that make us less well able to assess them clinically? The methods then, this was done on 20 stable hemodialysis patients, and each of these patients had their fluid assessed by the BCM machine and by at least 3 doctors, so house officer, reg, and consultant. Our statistical analysis was carried out using ANOVA, logistic regression, and Fisher's exact test. So, some results. As I said, this was done on 20 patients. 12 of these were female. The average age was 50, and there was a mix of ethnicities, but the most common were Pacific Island and Maori patients. We actually did a total of 79 clinical assessments. 26 of these were done by house officers, 26 by registrars, and 27 by consultants. And you can see in this graph here, actually, we did pretty well. The majority of the clinical assessments were within 1 kilo of the body composition monitor. And this was similar across groups. However, despite us doing pretty well, there was some significant outlying results as well. So for the rest of the results, I'm just going to discuss them in terms of clinician factors. And the clinician factor we looked at was the grade of doctor. Clinical factors, so they're things like BMI, albumin level, that patient factors that might assess our ability or affect our ability to assess them, and also what the patient's actual volume status was. So if a patient was underloaded versus euvolemic versus overloaded, how did that affect our ability to assess them? So clinician factors first. This graph here shows the difference from the BCM measurement, and it's divided up by the grades of doctors. And actually, surprisingly, there wasn't a significant difference between the groups. For this graph, we analysed the same data a bit differently. We looked at the percentage of assessments that were within 1 kilo of the BCM. So we decided that that was what we were defining as accurate, was within 1 kilo of the BCM. And actually, we found the registrars had the highest percentage of accurate assessments, which we were happy to find. When we looked at the clinical factors then, looking at BMI, we found having a high BMI, and that was a BMI greater than 35, was associated with a bigger difference from the BCM compared to the other groups. And although it wasn't statistically significant, there was a lower percentage of accurate assessments in the high BMI group. When we looked at cardiac function, and we looked at right ventricular dysfunction, we found that moderate right ventricular dysfunction was very strongly associated with a big difference from the BCM measurement. We actually didn't find the same thing with the severe or RV dysfunction, even though we would have expected to find that. But there was actually only one person in our group who had severe RV dysfunction, so we think that explains the problem there. And as expected then, having moderate RV dysfunction was associated with a really low percentage of accurate assessments. We looked at blood pressure then, and this was a bit of a surprise as well. The main thing we found was that having low blood pressure was associated with a big difference from the BCM measurements. And actually, none of our patients with low blood pressure had an accurate clinical assessment. We also looked at albumin, and in this case we found having low albumin was associated with a big difference from the BCM. And again, they had a lower percentage of accurate assessments. The next thing we looked at was the volume status, so what the patient's volume actually was. Were they underfilled, euvolemic, or hypervolemic? And the biggest difference was actually found in people who were hypovolemic. They had the biggest difference from the BCM measurement. The people who were euvolemic had were the closest. And again, no one who was hypovolemic had an accurate clinical assessment. So the limitations of this study then, obviously the biggest limitation is that it was a small study. We only looked at 20 patients, so some things we wanted to look at, like for example that there only being one severe RV dysfunction, we couldn't look at properly. Despite this, we had 79 clinical assessments, which was actually really good, we thought. The other thing is that it was done on inpatients. Ideally this would be done on outpatients, but logistically we couldn't get 3 doctors of 3 different grades out to an outpatient place at the same time. So it had to be on inpatients. They were very stable inpatients. And then our discussion points. In general, we were pretty happy, pretty reassured that clinical assessment was pretty good. We did find some clinical factors that decreased accuracy, for example, high BMI, RV dysfunction, and low albumin. We didn't find there was any improvement with experience, and if anything, we found regs were the best. And it made us think about the role that we could have for the BCM in our department. And we thought it would be most useful in people who we really feel that we're struggling with getting the target weight right, and people who have at least one factor that decreases our accuracy, for example, high BMI. These are the references. Thank you. Any questions?